Welcome to the ECG 5-Minute Consult, brought to you by paramedic Troy Kennedy, Dr. John Hayden, and myself, where we guide you through the basics of ECG interpretation based on the primary survey approach from our book, ECG for First Responders, available on Amazon. Let's get started on today's case. You arrive on scene to find a 48-year-old female who works as an electrician. For the past 2 hours, she has been experiencing epigastric pain that she states feels like indigestion. This pain is associated with nausea and weakness, however the patient denies emesis, chest pain, and any other complaints. She has a history of type 2 diabetes and hypertension, both of which have been well controlled with metformin and hydrochlorothiazide respectively. As part of your assessment, you obtain a 12-lead ECG, but before we look at that, let's briefly review the primary survey approach to interpretation. We use the primary survey approach as an organized approach to ECG interpretation, wherein we seek to answer these 4 questions. Is the heart rate too fast or too slow, causing cardiovascular instability? Is the rhythm supraventricular or ventricular in origin? Are the ST segments consistent with an ST elevation myocardial infarction STEMI, or a non-ST elevation myocardial infarction NSTEMI? And are the T waves consistent with STEMI or NSTEMI? With this in mind, let's take a look at this patient's ECG. While looking to determine this patient's heart rate, we see that the rhythm is irregularly irregular. So to get an accurate idea of the rate, we will need to count the total number of QRS complexes within a 6-second period. As each large box represents 0.2 seconds, 5 large boxes will then equal 1 second, and 30 large boxes will equal 6 seconds. In order to help you visualize the 6-second period we're referring to, we have highlighted the large boxes with the bold green lines. So in this 6-second period, we will count out 9 QRS complexes. Since we have to multiply 6 seconds by 10 in order to equal 60 seconds, or 1 minute, we'll need to multiply 9 by 10, which will give us a heart rate of approximately 90 beats per minute. You go on to obtain a complete set of vitals, which gives you a blood pressure of 140/90, the heart rate we just determined as 90, the respiratory rate you find to be 16, oxygen saturation 94%, and temperature 98.6 degrees Fahrenheit. So this indicates that the patient is hemodynamically stable, at least for the moment. Looking at the R to R intervals, we can tell that this rhythm is irregularly irregular. There are also no visible P waves preceding the QRS complexes. The complexes themselves are approximately 2.5 small boxes wide, or 0.10 seconds, and as that is less than or equal to 3 small boxes, 0.12 seconds, we will call them narrow. With an irregularly irregular rhythm, narrow QRS, and no discernible P waves, there's a good chance we are looking at a supraventricular rhythm, such as atrial fibrillation. Moving on to the ST segments, we see that there's elevation in leads 1, 2, AVL, AVF, as well as V3 through V6. We see that there's ST segment depression in leads AVR and V1, while lead 3 appears to be mostly isoelectric, and lead V2 is non-diagnostic as it just shows artifact. Now for the T waves. The T waves are upright and normal in the limb leads, as well as inverted and normal in leads AVR and V1. Remember, the T waves are supposed to be inverted in AVR and V1. We can see that there is some inversion and flattening in leads V3 and V4, while V5 and V6 are not fully discernible. Now we will briefly revisit the context in which we see our patient. Important to note that myocardial infarction can occur with an atypical presentation, especially in 3 particular patient populations: the elderly, females, and those with diabetes. Our patient has 2 out of these 3, which makes her reported symptoms of indigestion more suspicious of cardiac origin. Given this patient's increased risk of acute coronary syndrome, which is a term that includes STEMI, NSTEMI, and unstable angina, you decide to administer aspirin. That is, after inquiring about allergies and ensuring no contraindications. Now that we have aspirin on board, which of the following options would be the next best step in the management of this patient? A. Administer alteplase 15 mg IV push. B. Initiate transcutaneous pacing. C. Call a STEMI alert and transport. D. Repeat ECG ensuring proper lead placement. Or E. Administer calcium chloride 1 gram slow IV push. The correct answer is D. Repeat the ECG, ensuring proper lead placement. I know this was kind of a tricky one, so let's take another look at the ECG so you can see what I'm talking about. Did you notice that the R waves are upright in AVR, while the R waves of the limb leads are inverted? Something about that just doesn't look right and is suspicious for improper lead placement. In this example, the mistake was actually made by reversing the right arm and left arm leads. Let's fix the position of the leads and see what the ECG should really look like. Here's the first ECG with the right arm left arm lead reversal, and the repeat with proper placement. Always remember to double check your lead placement if something seems funny. Now that we have fixed our lead placement, let's quickly repeat the primary survey and see if anything is significantly different. Using the method that we did originally to determine the heart rate, we're going to do that again, and we get the same result, a heart rate of 90 beats per minute. The rhythm still appears irregularly irregular, with inconsistent R-to-R intervals and absent P waves. The QRS appears slightly wider in the repeat ECG, but it's still narrow, that is less than or equal to 3 small boxes or 0.12 seconds wide. Looking at the ST segments, there appears to be ST elevation in V1 and possibly in AVR, though that's less clear. The ST segments in leads 1, 2, V4 through V6 show what might be ST depression, though the quality of the ECG isn't perfect, and this may actually be due to abnormal T waves. The remainder here appear unremarkable, but given this patient's gender, comorbidities, and symptoms at presentation, there is a concern that this could potentially be a non-ST elevation myocardial infarction or NSTEMI. The T waves appear upright and normal in leads 3, V2 through V4, while the T waves appear inverted or biphasic in leads 1, 2, AVL, AVF, V5, and V6. These T wave abnormalities can also fit the picture of a potential NSTEMI. So without further delay, let's get this patient packaged up and off to the hospital for further evaluation. Well, that's all for today. We hope you've enjoyed this edition of the ECG 5-Minute Consult. If you'd like to learn more about the basics of ECG interpretation, check out our book, ECG for First Responders, available on Amazon. We look forward to seeing you again next month.